I'm Sandy Friedman, and I'm here to talk about ADHD and medication-treated preschool-age children without and with ASD. We all know there's been a significant increase in the diagnosis of autism as well as an increase in the diagnosis of ADHD, and these two conditions commonly co-occur. However, there's been a lack of published studies evaluating medication responses to stimulant and A2A medications in preschoolers with ADHD without and with autism. Prior research has shown that stimulant medication has lower rates of effectiveness in school-age children with autism and ADHD, and we hypothesize that the same would be true for preschoolers. This was a retrospective manual electronic health record review at 7 DBPNet sites across the country. Preschoolers were less than 72 months of age, diagnosed with ADHD, and started on stimulant or A2A medication by a developmental behavioral pediatrician over a 3.5-year period. We excluded those with moderate or severe global developmental delay or ID, those on psychotropic medication at the time of or prior to their initial DBP visit, and those on A2As for sleep. We abstracted data looking at demographics, coexisting conditions, medication effectiveness, reason for discontinuation of a treatment interval, and adverse effects. There were 497 preschoolers with ADHD, 389 of whom did not have autism and 108 did have autism. There were no statistically significant differences in demographic variables between these two groups, and the demographic variables are noted on this slide. For coexisting condition, those with ADHD and autism had more sleep problems. However, no statistically significant differences were seen in other conditions, and these conditions also are noted on this slide. For medication effectiveness, those with ADHD without autism were significantly more likely to improve with stimulants compared to A2A medications. However, those with autism and ADHD had no differences in effectiveness when looking at stimulants versus A2A medications. Also, there were no statistically significant differences between the two groups when looking at reason for discontinuation of the treatment interval. For adverse effects, those with ADHD without autism were statistically more likely to experience appetite suppression and stomach aches when treated with stimulants. There were no other statistically significant difference with autism status and rates of other common adverse effects such as weight, headache, sleep withdrawal, aggression, mood, dizziness, daytime sleepiness, and repetitive behaviors. So the novel finding of the study revealed no statistically differences in medication effectiveness of stimulant versus A2As for the group with ADHD and autism. There were higher rates of adverse effect of appetite suppression and stomach ache in those with ADHD without autism when on stimulant medication. The reason is unclear, although possibly due to no notable change in existing symptoms in the group with autism, given their high rate of GI symptoms. In conclusion, there are more similarities than differences between the two groups. There's overlap in many demographic variables responsive to medications, coexisting conditions, and effectiveness of medication classes. There was a statistically significant difference in response in sleep problems for those with autism, which is consistent with prior literature. In terms of medication effectiveness, stimulants were significantly more effective in the group without autism, and for those with autism, there was similar effectiveness for stimulants versus A2As. So overall, medications prescribers may wish to consider medication choices based on other coexisting conditions, timing of medication, and potential adverse effects. Thank you.